Bismillahirrahmanirrahim. Assalamu alaikum. On behalf of SOGP office and the whole executive and academic board of SOGP, I welcome you all on this skill session webinar. The skills we are going to do today are transvaginal tape insertion, TOT insertion, and internal iliac artery ligation. I have a very august panel of chairpersons with me and two wonderful dedicated speakers for today's webinar. I'm hopeful that this session is going to benefit all of us together. I am really grateful to all those who have linked us on Zoom as well as Facebook, and they are really doing great in terms of learning together in this challenging time through this innovative approach of virtual learning. Thank you, SOGP, for giving us all this opportunity to learn together. The first speaker for today's session, Dr. Nuvera Chughtai. Dr. Nuvera Chughtai is a budding, wonderful urogynecology consultant from Aga Khan University. She is an assistant professor at Urogyne department and also is running as a director the postgraduate program of Aga Khan University training. I am very grateful to her department, especially Dr. Raila Mohsin for sending her here with us today, Dr. Laman Sheikh, the chair of Aga Khan University, for sending Nuvera to us today for this session. Thank you, Nuvera, for always being with us whenever we need you.
Assalamu alaikum everyone and welcome to the webinar. Today the topic of my presentation is stress urinary incontinence in females. My name is Dr. Nuvera Chughtai and I work as an assistant professor in the Department of Obs and Gynae at the Aga Khan University Hospital. I've done my fellowship in urogynecology and pelvic reconstructive surgery from the same institute, and today I'm here to specially demonstrate the skill regarding the slings for stress incontinence, and we'll do that after the presentation. First of all, let's talk a little about SUI, or stress urinary incontinence, which is a common and bothersome problem that frequently requires operative management. Over the past 2 decades, novel techniques have been introduced into clinical practice and they've come into great controversial issues also. With a great variety of surgical options now available, there's an increasing focus on selecting the appropriate sling or the appropriate method or the appropriate device for sling for stress urinary incontinence. In the world, approximately 10% of all women experience urine leak at least weekly, making stress incontinence the most common type of incontinence in the world for about 50% of all people. So basically the current concepts have come in and future directions have been devised. So this is a paper which was published as Evaluation and Classification of Stress Incontinence in 2016, which said that an understanding of the pathophysiology was mandatory before learning the surgical skill for stress incontinence or to manage stress incontinence anyways. These mechanisms are not entirely separate. They may appear dichotomous, but rather they represent a continuum with many patients having the feature of both. The first ever theory which came into being was Einhorning, which is the urethral hypomobility, which said that the descent of urethra below the pelvic floor during stress due to anatomical defects in the pelvic floor, which can be induced by pregnancy, delivery, menopause, or surgery, they result in insufficient urethral closure pressure and a pressure transmission deficit resulting in leakage of urine. This was given in 1961, followed by the B. Lancey's hammock theory, which stated that the pelvic support is very important, and when there is a lack of pelvic support, that leads to urethral stress incontinence. Then came the most important theory on which the slings are based on, and that is the integral theory, which said that the pubourethral ligament basically is lax, and therefore again the external supports of the urethra are lax, leading to a urethra which is partially open at rest. It doesn't give you the original closing urethral pressure, leading to stress incontinence. That gave us an ISD, which is the intrinsic sphincter deficiency. Intrinsic sphincter deficiency is an intrinsic defect in the sphincter, which may result from the direct injury to the urethral sphincter or due to any dysfunction of the somatic or autonomic innervation. What it does is it damages the urethral sphincter. It causes the inability to generate enough outlet resistance to keep the urethra closed at rest or in cases of stress, leading to insufficient urethral closure pressure and a pressure transmission deficit, ultimately resulting in urine leak. So first of all, before providing any surgical treatment or to say for any treatment for stress incontinence, what we need to do is basically take a detailed and appropriate history followed by an examination including a cough test, followed by a pad test if you need to do so, and then urodynamics in certain situations. Please remember that urodynamics are not mandatory in all cases of stress urinary incontinence, where they assess the role of urodynamics in the management of female stress incontinence. So in 2018, they published a paper and they concluded that in an uncomplicated case of stress incontinence, the pre-op urodynamics does not prove to be really important. But at the same time, it provides additional information regarding additional dysfunctions of the lower urinary tract that can guide you to make the right therapeutic choice in the patient. And they should be considered mandatory before surgery in complicated patients who might have a mixed symptoms, who might have LUTs in addition to stress incontinence, and should also be evaluated in index patients when the results may help in counseling the patients pre-op, so they don't end up having a separate surgery, let's say 3 months or 6 months down the line. We all know that bladder is an unreliable witness. And when we do the urodynamics, we need to ask ourselves 3 questions. Is the underlying cause predominantly urethral hypomobility or IST or a combination of both? Is there something coexistent going on, such as overactivity of the reducer or reduced compliance that is contributing to this leak? Or is there any evidence of bladder outlet obstruction, reducer underactivity that may basically put the patient at risk for post-op urinary retention? So basically in 2018, they came up with a care pathway for management of female stress incontinence. This was in Italy. And they said that women with stress incontinence, after a detailed history exam and urodynamics if needed, can be divided into basically mild SUI or moderate to severe SUI. The initial 3 months of treatment should consist of lifestyle modification, pelvic floor rehab, and local therapy. And then if the patient is refractory to all of these treatments, then basically we can go on with the surgical therapy with mid-urethral slings, or even if they don't work, now the stem cell techniques and bulking agents have come in. So these are the conservative therapies. We can all try this in the first 3 months, which can be pelvic floor muscle training, pessaries, which are for stress incontinence, and prolapse at the same time too. Duloxetine is a medical treatment, which can contribute to 40% improvement in some cases, followed by estrogen or laser therapy, which is a YAG laser now coming in, with some FDA precautions also. But basically the domain of this presentation is surgical options or slings for incontinence. So initially, anterior colporrhaphy with a Kelly stitch was considered appropriate, but then that went behind and came the bladder neck needle suspension procedures like Prera and Stamey's. But then came Birch colposuspension, which till the 1970s was considered as the gold standard for stress urinary incontinence management, which is basically an abdominal procedure. It can be done by a laparoscopic approach too. And then came the slings, the most fashionable, the most controversial procedures to date, followed by periurethral injections in cases of sling failure, and then an artificial sphincter. But please remember that the practice can vary with local norms, experiences in training, with influence of the manufacturers has been very important in the last 2 decades, but individual surgeon practices and consideration of a new procedure. According to a journal in European Urology in 2009, they commented that clinical research is a must prior to introducing any new device and surgical innovation, and should be initiated and infused by experienced surgeons and trained surgeons from academic medical centers rather than by the industry. I think this is one of the most important reasons that we're doing this presentation today. Coming up to the topic of mid-urethral slings. Mid-urethral slings can be synthetic, they can be autologous. We'll first discuss the synthetic slings, which are basically 2. First is a tension-free vaginal tape, which is TVT procedure, and the second is a transobturator tape, which is basically a V-shaped sling. The difference between 2 slings is the mesh is the same, the trocars are different, but as you can see, the TVT is basically a U-shaped tape which would go under the urethra and come out through the retropubic space just above the pubis. But please remember, it's an extraperitoneal procedure. Secondly is a TOT, which is a V-shaped tape, which would basically support the pubourethral ligament, or basically substitute the pubourethral ligament, but it would be a V-shaped tape because it would come out through the obturator foramina on bilateral both sides, and then come out through the thigh. So you can see the shape of the sling is different. These are the two procedures we're going to talk about, and we're going to tell you a little bit about the procedures and the details of the procedures also. These are the third generation slings, which are called the mini slings. As you can see, they're smaller than the TVT and the TOT, and they anchor themselves into the fascia. You don't need to pierce a certain space or a foramen for these mini slings. The indications of sling, especially for TVT, can be any type of SUI leading to any theory, that is urethral hypomobility or intrinsic sphincter deficiency. With TOT, it is said that the intrinsic sphincter deficiency would not be dealt with a TOT. So TOT basically treats urethral hypomobility. As a secondary procedure for relapses in cases of Burge or autologous springs or a simple stitch, then it can be easily done concomitantly with vaginal surgeries, with anterior colporrhaphy, posterior colporrhaphy, vaginal hysterectomies, and reconstructive procedures like hysteropexies and vaginal fixation procedures. So TVT was considered as the gold standard, but then in 2011 there came a study which said, do we need to change a winning horse? Do we need to prefer TOT over TVT? And it was called the Thomas study, very famous study in urogynecology, which considered the adverse events over 2 years after retropubic or transobturator mid-urethral sling surgeries. What they did was they took 597 women over a 24-month period after randomizing them to a TVT or a TOT sling procedure. And they concluded that altogether among 597 women, there were 383 adverse events in 253 women. That is 42% of the women experienced some kind of complications, minor or major, out of which there were 75 adverse events, that is 20% of women, and serious adverse events in 70 women out of 597 women, which included the intra-op bladder perforation in TVT exclusively. Neurological adverse events were more common in the obturator group than in the TVT group, that is 32 versus 20. And 4% of the women experienced mesh complications, including exposure, exclusion, rejection, infection, migration, and erosion. And that included the delayed presentations also. They concluded that basically TOT and TVT were comparable as in terms of side effects, and you can do both, right? So there was no statistical significance, especially except for the retropubic, in cases of retropubic sling, the intra-op bladder perforation, which was exclusive to TVT. This was another study published in 2018, TVT versus TOT in the treatment of female stress incontinence. It was a systematic review and meta-analysis involving 28 RCTs with about 2,500 patients approximately in each group. They had the results that TOT may have more valid effects than TVT in operative time and hospital stay, but TOT method showed fewer complications, especially bladder perforation and blood loss than TVT, but the success rates were comparable. There was no statistical, they were not statistically significant. So these are the pros and cons of the TVT and the TOTs. Again, the same things. Okay, so basically higher rates of post-op voiding dysfunction in TVT versus TOT, but TOT at the same time had higher rates of groin pain and sexual dysfunction, dyspareunia. These are the complications of sling, which can be bleeding, bladder injury in TVT, urethral injury while dissecting, urethral erosion, intestinal injury if you go too far off with TVT, which was rare, vaginal erosions, UTIs with partial urinary retentions, pain, de novo urgency, bladder outlet obstruction due to a tight tape, secondary to urinary retention. But then about 10 years ago, the synthetic mid-urethral slings had gained wide popularity because of their simplicity and excellent outcomes. The complications rate were again 3 to 4%, which involved sling removal or revision, which was an easy procedure to do. But due to the reports of complications, the FDA revised the sling they reclassified the surgical mesh repair, especially for prolapse. Please remember, not for incontinence, but for prolapse, to a class 3. That's a high-risk device in 2016. Media craved onto it, and then they had this hyped up negative attention, which also included the mid-urethral slings for stress incontinence. So people thought, what happened? Has mesh become a 4-letter word? Should we be using native tissue or mesh? And how many of the patients would require mesh reversal surgery? And what if the mesh would fail? So this is a brief history. 1996, slings were approved. 2008 till 2008, they were FDA approved. In 2010, the FDA started receiving about 3,000 complication adverse event reports. These were the complications that you can see. There was exposure, infection, extrusion, migration, and perforation of the bladder in the last picture. So the Lancet said that they tried to differentiate between the meshes for prolapse, that is the vaginal kits, these are the vaginal kits, versus stress incontinence. And they said although the meshes have a higher complication and reoperation rate, but the results supported the use of mesh procedures for incontinence, although further research on longer outcomes would be beneficial. This was a study done in Scotland from 1997 to 2016. This was a population-based cohort study, and they compared the vaginal prolapse meshes with the slings for incontinence. The American Urogynecologic Society had a position statement in 2019, and they said that the mid-urethral slings have been the most exclusively studied anti-incontinence procedure in the history, with over 2,000 publications in literature, with no other surgical treatment for incontinence before or since has been subjected to such extensive interrogation. But the synthetic slings are appropriate for women with stress incontinence. They have similar efficacy but less mobility than the non-mesh tip. Then came the very fashionable now, the mid-urethral facial sling on a string, which is considered as an alternative to mid-urethral synthetic tapes in the era of mesh complication. In a study which was published in European Urology in 2018, that was done over 106 patients who underwent a rectus fascia sling. 8.2% had a rate of de novo storage LUTs, with 2% long-term self-catheterization rates. And as you can see, as compared to 3%, these rates are comparable with the synthetic slings. So this was a Cochrane review also done in 2017. And the slings were found to have the advantage of a shorter operating time, no abdominal incision, fewer perioperative complications, excluding bladder perforation for TVT, and evidence suggesting that there was less post-operative voiding dysfunction and de novo stress activity with the slings. The take-home message would be that medical therapy should be initiated first, rehab should be considered as a first step treatment to SUI, but mid-urethral slings are the gold standard. They can be done with synthetic slings. It might be attempted with an autologous fascia sling. TVT and TVTO, which is the TOT, have long-term success rates. Autologous slings are a reasonable alternative and now in demand because of the FDA warnings. We're going to first discuss the TVT procedure. This is a video and I'm going to explain to you what is being done here. First of all, before doing anything, the patient would be in the lithotomy position, and we need to put in 18 French Foleys with continuous drainage, as you can see in the picture. Secondly, mark the suprapubic sites. The midline is marked from the clitoris above to the pubic symphysis, and the 2 points are 2 centimeters lateral to this line. The lateral you are, the more the chances of inferior epigastric vessel injury. So be careful, within these 2 centimeters, it's bladder injury. Outside these 2, it's 2 lateral epigastric vessel injury. About 2 centimeters below the urethral meatus, local infiltration is done at the mid-urethral level. So after the infiltration, which creates a plane between the vaginal mucosa and the paraurethral fascia, we make a 2 centimeter incision, 2 centimeter cephalate to the urethral meatus, and dissect with a metamam scissors. In cases of TVD, towards the ipsilateral shoulder, directed towards the ipsilateral shoulder, ideally until we reach the urogenital diaphragm. This incision would facilitate the trocar incision into the passage. Make sure that the bladder is empty, and then we enter a rigid catheter guide to deviate the bladder to the opposite size at the trocar you plan to insert. So if you're inserting the right-sided trocar, the bladder would go to the left and vice versa. The bladder is deviated to the left while the trocar would go to the right. Next, we secure the trocar sheath over the trocar shaft. The next step is to hold the trocar in the incision site and support it with your non-dominant hand in the vagina. Orient the tip in the frontal plane. You need to pass it until it reaches the end of the dissected space. This is how you hold it, with your other hand in the vaginal wall, below the vaginal wall, so that you can support it. Then pierce the urogenital diaphragm vertically to cross through the retropubic space to come out to the exit point that you've marked 2 centimeters lateral to the midline. You can either come out lateral to it, but not very lateral, not more than 5 centimeters to each midline. This is how the trocar is being passed through the retropubic space. So as the trocar comes out of the exit point, as you can see in the picture, the sheath is held by an instrument and the trocar is withdrawn back through the vaginal incision. The next step is to repeat the procedure on the left side by deviating the bladder to the right first. So from the left, the trocar also comes out. The sheath is held with an instrument and the trocar is pulled back. Next, remove the Foleys to perform a cystoscopy with a 70-degree cystoscope to help visualize the lateral walls of the bladder, making sure there is no bladder perforation either at the entry or the exit point of the trocar. If there is a perforation, you need to pull back the sheath with the mesh. This is how it should look at the end of the procedure. Pull out the sheaths, cut them to expose the mesh. The plastic sheath needs to be pulled out, and by keeping any instrument under the urethra so that the tape doesn't become too tight, pull out the plastic sheet. So there is your TVT mesh. The mesh is cut, the extra mesh is cut, and the vaginal incision is sutured with interrupted or continuous sutures. We're going to discuss the steps of the TOT procedure now. Starting off again as similar to TVT, with the dorsal lithotomy position, legs are taken up to 120 degrees with hyperflexion. We're going to do the marker of the exit site before we start off with the video. So basically what you have to do is mark the surface anatomy of the obturator foramen on the thigh. This would be a square, the top line of which would correspond to the line of the clitoris, just lateral to the thigh crease. And then the bottom point would be 1 centimeter below that point. So this would form a square here, which would represent the exit point through the obturator foramen outside onto the thigh. Foley's catheter again is in the urethra, and after doing a bilateral periurethral dissection, now directed in TOT towards the ischiopubic ramus of the ipsilateral side. With the help of a wing guide, this trocar is going from this incision through the obturator membrane and coming out through the exit point within the square that you marked. Again, the sheath is held up with an instrument and trocar is withdrawn back from the incision, as you can see. The sheath is pulled out. Similar steps are taken on the opposite side. You don't need to deviate the bladder here in the TOT procedure. Dissection is being done towards the ischiopubic ramus. The mesh is put onto the trocar. The trocar is inserted, taken up to the obturator membrane, pushed with a stop, pop, and drop technique and comes out from the thigh incision. During this passage from inside out, the trocar will pierce the obturator membrane, come out below the adductor longus, through the obturator externus muscle, the gracilis muscle, the subcutaneous fat of the thigh, and then the skin. Similarly, the sheath is pulled out, making the tape tension free under the urethra at the mid-urethral level. And then before tightening the tape, an instrument is kept between the urethra and the mesh after cutting the extra portions of the sheath and the mesh. An instrument is being placed so that the mesh doesn't become too tight. And the sheath is now pulled, exposing the mesh.
Thank you very much, Dr. Novera Chuktai, for a very nice presentation and wonderful skill demonstration on TVT, TOT, and the surgical management of stress urinary incontinence. May I now request the chairperson, Madam Professor Aisha Siddiqa, to give her worthy comments on this session. Dr. Aisha Siddiqa.
Thank you very much, Professor Halima Yasmin. I would like to appreciate all the efforts which are done by the SOGP. We are proud of SOGP. And in this era of COVID-19, our students, our postgraduates, our doctors, they are getting benefited by your webinars. And I hope, inshallah, this series will continue. So my comments on TOT, TVT will be that, as we all know that stress urinary incontinence, it affects 1 to 3% of the women under the age of 60 years and 5 to 11% of those over 60 years old. And as we all know that the stress urinary incontinence, it occurs because of the anatomical defect in the structures which are supporting the urethra and bladder. And the students must note that there is no role of urodynamics in the pure stress urinary incontinence. But whenever there is a mixed pattern of stress urinary incontinence plus bladder, overactive bladder, then there is role of urodynamics. Most of the time, our postgraduates, when they are asked about the investigations, if a woman has prolapse and she has cystocele and stress urinary continence, our students add in the list urodynamics. So this point should be clear that urodynamic has got no role in pure stress urinary incontinence. But whenever there is a mixed type of urinary incontinence, there is role of urodynamics. So the NICE guidelines do not recommend urodynamic studies for stress urinary incontinence with no symptoms of overactive bladder. And there are many surgical procedures like TVT, TOT, as Dr. Saiba very well explained. TVT mean transvaginal tape and TOT mean transobturator. So, and colpose suspension has also got the role in stress urinary incontinence. As we all know that it requires the expert. Everyone cannot do it. And most of the time, our young gynecologist, even myself, I'm not that much expert. So sometimes the problem after the surgery, which is performed for the prolapse, is the problem is aggravated. And आपका patient आपके पास आता है और कहता है कि डॉक्टर साहब जो मेरे यूरिन का प्रॉब्लम था वो तो ऑपरेशन के बाद और ज्यादा हो गया. So most of the time it is deferred, but nowadays the role of TVT and TOT, there is some debate on the role of TVT and TOT, but still we can use it. And The TVT is, as you very well explained, that TVT is a retropubic surgical approach. The principle is to support the urethra and urethrovesical junction by providing mechanical support and higher urethral closure pressure. The success rate of TVT is in good hands, 88 to 90%, while TVT is a mid-urethral tape which avoids the passing of the tape through the retropubic space. If you compare both the techniques, they are equally effective. But TVT reduces the risk of bladder perforation and is good for obese women. I hope both these procedures will be taught by workshops, by the experts, and our young generation. Once they get once they get expert in these procedures, they will combine it whenever they are performing surgeries for uterovaginal prolapse. They will perform it. Once again, I'm very thankful to SOGP for giving me the chance to listen this useful presentation and giving my comments. Thank you very much, Professor Halima. Thank you very much, Professor Razia Kurejo. We are proud of SOGP. Thanks a lot. Thank you, the team of webinar. Thank you, Sami. Thank you, Aisha, for taking me on board. It was my pleasure having this presentation. Thank you,
madam. The next speaker is ex-executive member of SOGP, currently a professor of obstetrics and gynecology at Services Institute of Medical Sciences, our very own Professor Tayyaba Wasim. Professor Tayyaba Wasim is currently an executive member of Lahore chapter, a very, very dynamic teacher who's willing to teach her students and her colleagues everywhere, anywhere. She has her dedicated interest for women health, especially for working for contraceptive services. She is the pioneer of starting PPIUCD program in her own institute.
Bismillahirrahmanirrahim. I am Professor Tayyaba Wasim from Services Institute of Medical Sciences, Services Hospital, Lahore. It's indeed a great pleasure to be speaking to you about internal iliac artery ligation. One of the procedures that most of us really don't know, and as we have not been trained during our training time to have this procedure done. And I am really grateful to Halima, Professor Halima Yasmin, for asking me to speak on this very, very important topic, because hemorrhage nowadays is the most common presentation that we all obstetricians fear. Or as the population is rising and as the number of deliveries are increasing, hemorrhage is the catastrophe that we all face. And Williams wrote very many years back that obstetrics is a bloody business. So all the good things associated with obstetrics end up in a nightmare if you see hemorrhage. And I am very glad that SOGP has taken up this very important webinar today. So this is how the uterus becomes when it goes into atony, and it pours liters and liters of blood in just few minutes. I always tell my class, whenever I take a final year class, that there are two hemorrhages in the body other than trauma, which can lead to patients compromise very early within few minutes to hours. Otherwise, all other hemorrhages take time. One is postpartum hemorrhage, as the blood can be lost within minutes. Liters and liters patient pour out, and the other are the esophageal varices. In that also, anybody can throw up 1 to 2 liter of blood immediately. Maternal mortality, still the severe bleeding hemorrhage is the leading cause of hemorrhage worldwide, because this one thing has not been able to be controlled by all measures. Other infections, eclampsia have been eradicated from the developed world. So coming back to our main topic, that is the internal iliac artery ligation, also known as hypogastric artery. It's a life-saving measure. Okay? Mainly it's done for the obstetrical hemorrhage, but sometimes you can need to learn it for gynecological hemorrhages as well. Internal iliac artery ligation is the final step in the stepwise devascularization of uterus. As you all are now familiar, the uterine artery, bilateral uterine artery ligation is the first step whenever you have interactable hemorrhage. As you can see in this figure, that uterine artery is the branch of internal iliac artery. Okay? And whenever you ligate this, the first step is to ligate the uterine artery bilateral so that the main supply of the uterus is stopped. In addition to that, you might have to ligate the ovarian artery as well. If both these arteries are still unable to stop the bleeding from the uterus, and in any way you have to conserve the uterus. These are all approaches for the conservative surgery, because day in and day out we are seeing that younger patients are coming, especially with placenta accreta. If you have practice around, you can see that the only 27 years old girl, 25 years old girls are coming with placenta accreta and placenta percreta, in which ligation of the main vessel of the pelvis, the main vessel, the internal iliac artery, becomes extremely important. If we stop this hemorrhage and the patient's uterus is saved, obviously she'll be not only it's important to have children after that, but at least saving the uterus spares her from the mental depression of losing a uterus at such a young age. I must say it's a need of an off hour, just because of the fact that placenta accreta is on a rise, and we are constantly seeing young girls, even less than 30 years, losing their uterus for the primigravida, sometimes just in the third or second baby, and the baby previously is not alive, just because of the fact that they are having placenta accreta. So this, if you know this surgery well, you are going to save the uterus of the patient. And I must say that SOGP should make an effort. We have 3 counselors with us who are gynecologists, to incorporate it in the teaching curriculum of postgraduate training in obstetrics and gynecology at CPSP level. So the indications are obviously to arrest hemorrhage. I think now uterine atony is number 2. It is the placenta accreta and percreta which have surpassed uterine atony now. Uterine rupture is one indication. If you have encountered uterine rupture, you see that the incision extends so much around, and you can have so much hemorrhage, and there's a broad ligament hematoma, and you are unable to see where the exact localized hemorrhage is. In that case, internal iliac artery ligation helps you in the stopping the hemorrhage, and believe me that collateral circulations develop ultimately, and the supply to the is restored to the pelvic organs is restored, and successful pregnancies have been reported after bilateral internal iliac artery ligation. Placenta previa and accreta I've talked about. Sometimes you have interactable hemorrhage after cesarean section, then it is easier to stop the hemorrhage by internal iliac artery ligation. Gynecological surgery, sometimes when the cancer surgeries are being done, for when it's supposedly you're doing a radical hysterectomy and you want to avoid so much of a hemorrhage, or there is a broad ligament hematoma due to a slip ligature, or abdominal hysterectomy for large fibroids, when the abdominal anatomy is distorted, and large fibroids can result in excessive blood loss. So at that time, electively, you can ligate the internal iliac artery for the lesser hemorrhage. It's very important timing of internal iliac artery ligation. I always speak about it, that there is a difference between reversible and irreversible shock. We keep on doing Meyer's when the patient starts to lose blood. Remember, it's the speed of loss that kills. If you are unable to stop the speed of loss and the patient has lost, but sometimes if you have done cesarean section of accreta or previa and you by chance give incision in that area where the blood vessels are, immediately 1 to 2 liter blood is poured out. And the patient is unable to sustain that hemorrhage easily, and this time interval she can go into shock. And if you don't stop the hemorrhage by that time, reversible shock can easily go into irreversible shock, because the patients are of our setup are generally anemic. They are unable to, they are already at a lower edge of blood, and they are unable to compensate. So the time interval of internal iliac artery ligation is very important. Don't delay the decision. The decision is very important when you have to take it. Okay. Now, internal iliac artery ligation, whenever it reduces the pelvic, whenever it stops, you tie the artery, it reduces the blood flow by almost 50% and sometimes by 100%. So by after ligating bilateral arteries, you just have to wait for some time, at least wait for 5 minutes, packing the organs and waiting for the blood to stop. It invariably stops the blood flow and hemostasis is secured. Now, the gist of my lecture is that I'm going to teach you a little bit of the anatomy, because if you do not know the anatomy, you won't be able to ligate it properly, and relation of various important structures around, that is the external iliac vein and the ureter, which need to be identified and saved. So I'm going to teach you on this lecture. Then we have a video on the model, but believe in me, model and live patient is a very different experience. So anatomy is there for you to familiarize with you for the main anatomy, this slide, and also the model presentation. Or I have demonstrated it on live patient, and I will request you to demonstrate it on live patients so that you familiarize with the anatomy whenever the patient is not bleeding. And I recommend you to practice it on live patient when the patient in elective surgeries, so that you are familiar with the anatomy, because otherwise in the hemorrhage situation you are panicked and the blood loss is so much and we sometimes are unable to do. So this is the main anatomy. We all know that the aorta divides into common iliac arteries and common iliac. This is almost happening at the lumbar 4 and 5 vertebra, and the iliac arteries, common iliac, divide at the sacroiliac brim to external and internal iliac arteries. The external iliac artery continues down and becomes the femoral artery, and internal iliac artery ultimately supplies the main pelvic organs, also the gluteal region. So this is where they divide, and this is how the ureter is crossing the bifurcation of internal and external iliac artery. Another view of the pelvis, this is a lateral view. You can see on the right side, this is the sacrum, this is the major muscles, this is the bifurcation, and this is the main internal iliac artery. This is the external iliac artery, this is the external iliac vein, and you can see the branches. Okay? It has got an anterior deviation and a posterior deviation. The internal iliac artery divides after 4 centimeter of its origin, almost 4 centimeter up, 4 to 5 ho sakta hai, but 4 centimeter pe generally divides into anterior and posterior trunk. The posterior trunk supplies the I'm going to just tell you the posterior and anterior trunk. These are the main arteries. These are the external iliac, internal iliac, and this is the main arteries of the posterior and anterior trunk. The posterior trunk has 3 arteries, These are the main arteries of the posterior trunk. Are three arteries, which is the iliolumbar artery, and it is superior gluteal artery and lateral sacral artery. Three arteries from the posterior trunk, superior gluteal, gluteus muscle को, iliolumbar artery and lateral sacral artery. And the all other branches are from the anterior trunk. Anterior trunk has 8 branches, which are the superior vesical, obturator, rectal, internal pudendal, and obviously uterine artery. These are the branches: common iliac, right and left, external iliac, internal iliac. External iliac becomes femoral artery, supplies the whole of the limb. Anterior deviant, posterior deviant. Posterior deviant has only 3 branches: iliolumbar, lateral sacral, superior gluteal. This is the anterior deviant that we plan to ligate. Umbilical artery, uterine artery, vesical artery, vaginal artery, obturator artery, middle rectal artery, internal pudendal artery, and inferior gluteal artery. So आप देखिए, this is supplying the vagina, the uterus, the rectum, the bladder, and ultimately the gluteal muscles and internal pudendal artery supplying the perineal muscles. So this is how anterior deviant is supplying all of the main vital organs which are responsible for bleeding. And once you tie this anterior deviant, the bleeding from all these vessels is going to stop. Telling you the anatomy again so that you familiarize with the anatomy first, that where the branches are being divided. This is the common iliac artery, this is the external iliac artery. आप देख सकते हैं, this goes down to the, it is going to the canal, and it is just going from out to that femoral artery. This is the internal iliac artery, dividing into anterior and posterior trunk. It is a cadaveric dissection, so that is why you are easily seeing it. Otherwise, there are so many blood vessels around that sometimes you are unable to see it very clearly. We are going to demonstrate you a live patient as well. In that, you can also see this bifurcation very easily. The external iliac vein is just lying here beneath it, beneath this artery. So that is why we always tell that the patient have to be very careful. और ureter इसमें dissect होके पीछे जा चुका है. So this is the anterior trunk of the internal iliac artery, and this is the posterior trunk. Posterior trunk is supplying all the lateral structures, and internal is actually supplying this. Internal iliac, all the branches that I mentioned, they are supplying the all of the pelvic organs. So this is how it is depicted, that there is a right pelvic wall, and you can see the various structures around. And this is the ligation point. This is the ligation point where you can demonstrate it that way. So the first step is to pick up the peritoneum over the sacral promontory. Because you have to have a bony landmark to pick up the peritoneum, you dissect that peritoneum and expose the retroperitoneal space. Whenever you are exposing that retroperitoneal space, you're going to identify the ureter just crossing the vessels, which you have to retract medially. And then you enter the laterals. I'll go a little bit lateral because these vessels, the internal iliac artery is not lying in the middle. Obviously, the internal common iliac is dividing into external and internal iliac vessels, which is on the sides. So I'm again going to say to you, these are on the side of the vessel. So you have to go not in the center. You open the peritoneum in the middle of the spine. Then you just go lateral so that you can see the loose areolar tissue, and then you go down, and you can just blunt finger dissection you have to do when there are vessels around. So you just do this finger dissection, open up the retroperitoneal space, and then you identify the vessels. These vessels will be identified like this. There are 2 vessels. The bifurcation will be very much obvious. And then you can put a Leahy's forceps going from lateral to medial side, and then you put a ligature and ligate it. If you are familiar with the anatomy and you know the right place to dissect, believe in me, it's just a 5 minutes procedure. So uterine artery ligation, the important thing is that bilateral artery, obviously we plan to ligate, but because left artery is hidden behind the sigmoid colon, because the sigmoid colon is passing over it, so right artery is easier to ligate. You can stop for 5 minutes. 5 minutes seems a lot to the gynecologist, but believe that you must stop for 5 minutes and wait for the blood flow to stop. If you are unable to go on the left side, but left side, if you take the rectum on the sigmoid colon, because it's a mobile area, if you take it on a side, you can approach the left artery as well. Okay, so it is where to ligate. Anterior levian should be ligated close to the uterine artery, at least 3 to 4 centimeters from the bifurcation. That is what I already told you. It should be ligated 3 to 4 centimeters from its bifurcation in from the common iliac artery. Okay. Patient should be in a lithotomy position so that you can assess the vaginal bleeding, but you can do it in a dorsal position as well, and you can see the vaginal bleeding after that. You have to open the abdomen, obviously, if you have not if you had done a normal delivery, but if you have there is no normal delivery in cesarean section, obviously the uterus is already there. Uterus should be taken out and bowel should be packed away using gentle finger dissection. Whenever you're going to open the peritoneum, parietal peritoneum over the sacral promontory, you are going to use a gentle finger dissection. Ureter is identified and retracted. You can see the ureter by peristalsis. It will be very much obvious passing under that peritoneum. It will be identified and it should be retracted medially to expose the retroperitoneal space, which is a little bit on the lateral side. Obviously, jaise anatomy hai, that is on the lateral side towards the psoas major muscle. So this is the anatomy exactly that you see whenever you're going to open up the space, and you are going to see this in my live video as well. This is the bifurcation of the common iliac artery. This is the external iliac artery going down. This is the external iliac vein, and this is the internal iliac artery. You see the close proximity of the vein and the artery. Ureter has been retracted medially. Ureter has been retracted medially. But this is the, if you are standing on the left side, this is the right-sided view. Or this is psoas major muscle which that's lying there. This is the external iliac artery. This is the external iliac vein, and this is the internal iliac artery. This you have to ligate. This is the next step. You dissect the artery completely free from the adjacent structures. Vein को आपने पीछे कर दिया, and the ligature is passed from lateral to medial side. ये बड़ा important step है कि आपने इस तरफ से नहीं डालना, क्योंकि वो आपको vein को puncture करेगा. That is just lying adjacent. So you pass Leahy's forceps, buy a Leahy's forceps, put it in every set. It just costs a few ₹100, and you just pass it underneath, and from here your ligature will be tight. You put non-absorbable suture from here. This will be demonstrable in my live video, and this is the way that you are going to ligate it. Place a non-absorbable suture, single or double, it depends. If you want to place it one here, it's all right. Place double ligature, and then it is always going to stop the bleeding. Wait for 5 minutes, see the bleeding. Pulsation of femoral artery, just to be on the safe side that you might not have tied the wrong artery. in that case, you have to go back in and you have to open up the ligature. Otherwise, gangrene of the limb will be there. So if your femoral artery is ligated by mistake, it's an important thing to do. And femoral artery, so you will pulsate there and then. In this case, the pulsation of the artery will be very much visible. It's a big arteries, both are, and pulsation will be visible to you when you are examining it. And this is how you ligate. Hopefully it will help you in ligation, and when the bleeding is controlled, it is known that it will be immediately after that vital size will improve. And if the bleeding still continues after 5 to 10 minutes of waiting, obviously you have to save the life of the mother and hysterectomy may be undertaken. This is a very important slide that I want you, this is my last slide. Please remember, practice makes you perfect. I will again advise you to see that you are doing it in a normal patient. Start doing it in a normal patient in which there is no hurry in elective surgery to familiarize with the anatomy. If you make yourself familiar, you will obviously going to be in a good place to do it at the time when the actual hemorrhage is happening, because you are already familiar with the procedure and your adrenaline is high and you want to save the patient, don't want to waste time when the patient is having active hemorrhage. So you are going to obviously save the baby. Thank you very much, and thank you, SOGP.
Bismillahirrahmanirrahim. I am Professor Dr. Tayyiba Waseem. I am working as Professor of Ops and Gynae at Services Institute of Medical Sciences, Services Hospital Lahore, which is a public sector medical college. And its attached hospital receives large number of obstetrics patients in emergency and also in booked status from all over Punjab. Postpartum hemorrhage is a very important complication that leads to maternal mortality worldwide. Today I am going to demonstrate to you the role of internal iliac artery ligation. Internal iliac artery basically is the main supply of the pelvic organs, and when the patient has so much of hemorrhage and we want to conserve the uterus, because if sometimes first or second baby gravida patients are having such problems, and sometimes very young patients are encountering hemorrhage. So this technique all residents and all people who are delivering should know. It's not that complicated, but generally we are not well versed with the anatomy. So a very important thing for you to remember is that you have to know the anatomy of the pelvis to encounter this problem, and you'd have to know the anatomy to just get the best results. So let's start. This is a uterus model. I am going to demonstrate it on the model. This is a uterus. Supposedly you have done a normal delivery or a cesarean section and you have opened up the hemorrhage is not settling, and we are going to demonstrate to you that how you are going to proceed. So first of all, exteriorize the uterus. You take the uterus out of the abdomen and do above from the way. This is the main layout of the posterior abdominal wall. This is the peritoneum broad ligament, which is there on the both sides of the vessels. We have just made it there to tell you that this is the broad ligament, which is, and if you just see that the broad ligament, this is the sacral promontory. Okay, I'm going to demonstrate to you. You can feel the sacral promontory. This is the bony structure with which you can see that how the vessels are going. Remember that the aorta divides into common iliac vessels at the L4, L5 vertebra, and then vessels are this internal iliac, and the common iliac divides into external and internal. I'm just going to show you in a while. This is the first thing to identify with fingers, the sacral promontory, where it is. Okay? So vessels, one will be on that side and the other will be on that side. So first of all, you lift the peritoneum. Peritoneum, you have lift karenge na, you will see that you can see across both the peritoneal sides. So you just cut the peritoneum above the in the center. This center cutting will help you to separate the peritoneum and opening up of the fossa or of the tissue. ठीक है? Okay. So this is the opening. Now I am going to see. You can see when you are opening up the tissue, this is separated. It is not that clear. I have demonstrated it on a live patient as well. इतनी आसानी से नजर नहीं आता, but just you have to remember that how the landmarks are located. So this is a aorta which is dividing into external and internal iliac vessels. ठीक है, ये देखिए दोनों तरफ से you can see this is the internal iliac vessel and this is the external iliac, which is going to become a femoral artery ultimately. ठीक है, ureter is crossing the vessels on. This is the way the ureter is, both ureters are crossing the origin of internal iliac artery ligation. So first of all, whenever you are going to see that the patient is having this ureter, आप ureter को retract करके medially कर लेते हैं. ठीक है, you just do retract the ureter medially. Here generally sigmoid colon is also lying, so you just separate the sigmoid colon on the other side as well. This is the internal iliac. You have separated this vein. The iliac vein is just lying beneath this vessel. This is the external iliac vein. And this is ultimately going into this is external iliac artery. This is external iliac vein. Okay. This is internal iliac artery. This is internal iliac vein. This is a normal anatomy. External iliac vein, internal iliac vein. अब आपने जिस समय सेपरेट करना है फ्रॉम दिस यूरेटर को आपने मीडियली लुक कर दिया. दीज आर द ब्रांचेस. इंटरनल iliac artery is divided into anterior and posterior branch. Anterior and posterior division is generally supplying all the lateral structures. It has got three vessels, three main supplies, which supplies the lateral side of the pelvis, and the anterior division, which is the supply of the pelvis. Anterior division divides into 8 more branches, which includes the vesical arteries, inferior and superior, which includes the obturator artery, which includes the uterine artery. All these branches are derived from the internal iliac anterior division. Now, how do you, once you separate it, you can see the bifurcation of both vessels very easily this way. Now, I am going to teach you this way. This is the, after 4 centimeter of common iliac artery, it divides into internal and external iliac. 4 to 5 centimeter via ke baad, it divides into the branches, and this is how when you expose it by dissecting the loose areolar tissue above the vessels, you can see this bifurcation very easily. ये आपको नजर आएगी bifurcation. ठीक है, bifurcation की आगे से anterior division आ जाएगी आपको, और वो आपकी main branches आपको जाती भी नजर आएंगी कि उसके नीचे जा रही है. अब this vein part is just lying इसके साथ. ठीक है, दिस इंटरनल iliac आर्टरी की जो बाइफिकेशन है ना, उसके नीचे बिल्कुल वेन पड़ी हुई है. ठीक है, आपने यूरेटर को मीडियली कर लिया. दिस इज हाउ इट इज. इसके साथ ये वेन है. तो नाउ यू इंट्रोड्यूस द लेहीज फोर्सेप्स फ्रॉम लैटरल टू मीडियल साइड. ये लैटरल साइड है. दिस इज द वे यू इंट्रोड्यूस द लेहीज फोर्सेप्स. दिस इंटरनल iliac आर्टरी यू from lateral to medial side, taking care कि इसको आपने इंजर नहीं करना. If you try to insert it this way, you can injure the internal iliac vein. और से फिर hemorrhage start हो जाएगा. You just do it like this, lift up the artery and then pass a suture. Like suture. So this is the way that the girl, you can handle me, give me a suture. Okay. Suture will be a free tie जो कि आपने मैं भी इसको रखती हूँ फिर आपको बताती हूँ. Suture will be a free tie which will be given to me by the assistant. This internal iliac this way. आपने उसके नीचे से डालना है और उसके बाद you have to open it. ठीक है जी, पकड़ लें. This opening somebody will give me the tie. आपने इसको पकड़ के then you have to just go around and you just tie. One tie here. It is almost 4 centimeter long vessel and one tie here. It is this way you are going to tie, and this artery will be. This will stop the flow. ठीक है, ये आपकी tie हो गई यहाँ पे. It is to learn the anatomy thoroughly. Know where the landmarks are, then it is not that difficult. Thank you very much. जी बिस्मिल्लाहिर्रहमानिर्रहीम. आज we are going to demonstrate to you all the steps of internal iliac artery ligation. Internal iliac artery ligation is basically indicated in patients who have intractable hemorrhage, mostly after normal delivery or cesarean section, and where you want to conserve the fertility. Now it is common to have hemorrhage just because of the facts that the patients are coming more and more to the gynecology department, population is increasing, and then we start the for conservation of the uterus we have to control the pelvic hemorrhage by ligating internal iliac artery, which is the main supply of the internal organs. Yeah, the first step is to take out the uterus and expose the peritoneum in the over the sacral promontory. Okay, this is the way that you have to take the uterus out, and the aorta is dividing into common iliac vessels at 4th and 5th lumbar area, and then common iliac is dividing into external and internal iliac arteries close to the sacroiliac joint, and there you are going to separate the pelvic fascia, jo retroperitoneal fascia over that, taking care not to injure the ureter. You can see the posterior parietal peritoneum with the fat underneath it, and we will lift up the peritoneum around the area by feeling the sacral promontory. It is very important to have an anatomical landmark before you proceed. Expose the area widely, do everything under vision, because delicate structures are there. Ureter is crossing the iliac artery from above, and then it is lying medial to the artery, and the vein is inframedial, so you have to be careful while dissecting all this, okay, so that you don't injure the different vessels. Now coming to the dissection, you can see that we just hold up the peritoneum, and there is a loose areolar tissue beneath the peritoneum which you can dissect. आपने इसको you have to dissect it towards and inferiorly, and expose the loose areolar tissue which is covering the vessels. You should do it by blunt dissection, so that it is easily separated. While doing the dissection, you will be able to see, after you separate the area, you palpate the promontory again and see whether you are going in the right direction. Do it gently. There is no need to panic. There is no need to hurry. Just have your nerves with you and dissect it gently, feeling the pulsations of the arteries which you will be able to pulsate. Expose the area widely with the blunt and sharp dissection. Sometimes you have to use a cautery as well for smaller vessels which are there. And psoas major muscle is just lateral to the vessel. It is almost lying on the external iliac is lying on the psoas major muscle, and you can dissect it. You can see the ureter, while whenever you are dissecting you can feel the peristalsis by touching the uterus, and you have to displace it medially. उसको आप medially displace कर लें, and so that you don't injure it. It's just lying underneath the peritoneum and it crosses the internal iliac artery and before entering the bladder. Expose the area properly. अगर आपको ज़रा सा भी लग रहा है कि उसमें नहीं है, पीनट्स ले लें. जो आप ब्लंट डाइसेक्शन से नीचे जाएंगे, you are going to see the vessels. This you can see the one vessel is very much visible. This is internal iliac artery. You can see the pulsations as well, and this pulsation is visible. Now this you can see the division of internal and external iliac arteries. ठीक है, this is the internal iliac artery. This is the main vein. आपके सामने नज़र आ रही है. Internal iliac vein is lying underneath it, और इसमें ये bifurcation है common iliac की. थोड़ा सा आप sacroiliac joint है नीचे, उसके साथ आगे ये vessels हैं. Laterally psoas major muscle है. यूरेटर आपने मीडियली हमने इसको पेरिटोनियम के साथ ही साइड पे कर लिया है. द यूटिल हैज़ बीन डिस्प्लेस्ड. नाउ द नेक्स्ट स्टेप इज़ टू get Leahy's forceps. This is an artery forceps we are using. If you don't have it, you have to lift up the vessel. The trick is to move from lateral to medial side. Lateral से medial जाने का मकसद ये है कि जो आपकी main vein is not injured. If you want, you will be going from medial to lateral side, there is every chance that you can puncture the vein. So इसलिए you have to be very careful. You move from lateral to medial side. The Leahy's forceps you go from lateral to medial side, and you just get a tie, free tie, and then you pass it under the underneath the vessel and to tie it.
You have done a great job, a wonderfully presented session on internal iliac artery ligation. So for comments from the chairs, may I request Madam Professor Nusrat Shah, Executive Member SOGP Council, Professor at Dow University of Health Sciences, to comment on this wonderful session conducted by Dr. Tayyaba Wasim on internal iliac artery ligation. Over to Dr. Nusrat Shah for comments.
Thank you very much, Halima. Thank you very much for giving me this opportunity to chair this session, and also for arranging this very important session. Because I think these things are usually not addressed in our seminars and our usual teaching sessions. It's something very, very rare to address internal iliac artery ligation and also TVT procedures and stress incontinence. So thank you, SOGP, for organizing this online conference also, and these pre-conference workshops also. It's a great job that you people are doing, and I highly appreciate everybody's efforts. And I'm really happy to hear what Tayyaba had to say. It's always a pleasure to listen to Tayyaba. And thank you, Tayyaba, for your great, wonderful presentation on internal iliac artery ligation. So we all know, I would like to basically be addressing our trainees and our PGs and residents that internal iliac artery is a very, very important life-saving skill. And I think it's a responsibility with all of us supervisors of CPSP that we should be training our residents and trainees, as this is a life-saving procedure and you can need it at any time. Even if you are doing a cesarean section for a very normal indication, not necessarily eclita. Even if you are doing a cesarean section for multiple pregnancy or for preeclampsia or whatever, anytime you may encounter heavy bleeding PV and all of a sudden PPH you may encounter. And so this is an important skill, particularly when we are talking about young patients where we want to preserve their fertility, we want to conserve the uterus. Then I think the most important skills that we have to teach apart from B-Lynch, I know our residents are very good in doing B-Lynch and also uterine artery ligation. But internal iliac artery ligation is a skill which is difficult to basically accumulate the experience and to perform. And I think this is a neglected field. And this is a great opportunity to highlight that this we must train our residents. And another thing I want to highlight is that our College of Physicians, we should give them this feedback that they should put it in the assessment. Once we put it in the OSCE, then everybody will be more alert to teaching and training. Our supervisors will be very much alert. They will be starting these workshops and skill training workshops, and residents will actually demand that we want to do this procedure. And so they have to be trained, and there should be no compromise, because you know that most of the time vascular surgeons may not be available. General surgeons, you might be looking for them, but sometimes they're not available in every setup. We can't have an ideal setup where you get a vascular surgeon, general surgeon, urologist, everybody. So the basic skill, life-saving skill, should be very much into our training and our assessment and our teaching, because we cannot, particularly because you can always go for a hysterectomy, but that will compromise the fertility of a young woman, particularly if she's a primary gravida or a second gravida. So this is a life-saving skill. Along with uterine artery ligation, we must conduct these workshops. And thank you, Halima, for highlighting this important thing, because this was a much needed intervention that we need to teach our residents and our trainees and put it in the assessment also. So this message should go very clearly to the CPSP. And it's a good thing that Aisha is here. Aisha is from representing CPSP also. And I would like to thank Aisha for being here with me after a long time, seen her after a long time. So Aisha can give this feedback in CPSP that please we can, or we can do it also. We go for talk setting. We can also start putting it in assessment in our OSCE, in our talk station, so that residents start thinking about it and trying to learn. This is a very important skill and should not be neglected. And this was a wonderful session. Thank you again, Halima. And Dr. Razia, I'm missing her over here. Thank you, Dr. Razia Corejo, for organizing these teaching seminars. And this is the SOGP mandate, basically, that the prime responsibility is to teach and train. And thank you for asking me to be here. Thank you, everyone. Thank you to the audience. And thank you to the wonderful speakers that we have, both Dr. Novera, Dr. Tayyaba, and my colleague Aisha, and Halima, of course, and your team.
Thank you.
SOGP team is always proud of SOGP team.
It's always a pleasure to have you, and the way you bring in the trainees' perspective to every skill session. Thank you, Nusrat, for your dedication towards the cause for training. We definitely endorsed your words, and also I'm grateful to both the speakers who have done a great justice to their topics, and I'm really grateful to both the chairs for the session today and all the audience who have connected us on Zoom as well as Facebook. That this shows your dedication towards your own learning. Now is the time that we are responsible for our own learning, and we need to keep ourselves abreasted as well as updated for upcoming evidence-based practices. And these skill sessions are just the first step towards that cause and vision and mission of SOGP. Thank you very much.